Good morning. My name is Kristine Erlandson. I'm an associate professor at the University of Colorado and an infectious disease trained physician. And we'd like to end this year's meeting with an interactive presentation and discussion. We've talked about many complex issues around the care of older with HIV throughout the meeting, but we still don't have a great sense of how to actually integrate all of these concepts into clinical practice. As care for older adults with HIV has become more and more complicated, there has been an attempt in many settings to integrate geriatric and HIV care. But can this be a universal approach? Is it site-specific? And what elements do or do not work? There are currently several models investigating the integration of HIV in geriatric care, as you can see on this table. Today, we're going to hear from Drs. Bofito, Green, Schmalzi, and Siegler about some of their positive experiences, as well as their struggles in starting successful programs. However, I'd like to start this talk with some approaches that have been less successful so that we can learn from both experiences. We started a program at the University of Colorado primarily to address the complaint that patients needed a geriatrician and couldn't necessarily be referred to the geriatrician because they limit new patients to a certain age. We found a geriatrician that was willing to see patients with HIV regardless of age, and she facilitated a referral to our seniors clinic. Our seniors clinic was located in the same building, but a different floor as our HIV clinic. Unfortunately, she wasn't able to see patients actually in the ID clinic due to billing. We advertised this service throughout the clinic and the pharmacy. We sent recruitment emails to all of our providers several times. Our pharmacists and students actually reached out directly to about 200 patients that were 50 or older to let them know about the program, particularly targeting those that had multiple medications and polypharmacy. Over the course of about 18 months, we had relatively few referrals and many more no-shows. In fact, we only had about 11 patients that completed at least one seniors clinic visit over that time period. We did identify a lot of geriatric conditions. As you can see in the table, we had about half of our patients that had falls, hearing loss, or urinary incontinence. The majority had vision loss, and a few were identified as newly cognitively impaired. The average number of medications was quite high, with almost 18 medications per patient. Many of those were high-risk medications, and our pharmacists working with us helped to recommend stopping many of these medications with fairly limited success. Many other topics were addressed, including screenings for osteoporosis and cognition. Patients' advanced directives were filled out, and driving safety was often assessed. Some of our recommendations weren't completed, and this was oftentimes because the patient felt overwhelmed, didn't want to go to see multiple different providers, never scheduled some of their follow-up assessments, or really did not have a desire to stop the high-risk medications the pharmacist had recommended. So some things certainly went well. And, those included that older patient, or the providers with these complicated older patients really appreciated the input. We had a geriatrician who was very willing and interested to see patients with HIV. New medical issues such as cognitive impairment, urinary incontinence were identified and able to be remedied in some of the patients. Additional screenings were accomplished, advanced directives were addressed. Some very complicated patients actually continued their care in the geriatric clinic. And this was a very simple program. We didn't require any additional funding or grant support to keep things functioning. However, we also had a lot of barriers to success. We had fairly little uptake from our providers and patients. I think a lot of the providers didn't necessarily appreciate the added benefit of a geriatric consultation and that geriatric perspective. And our patients oftentimes didn't actually see themselves as old and see the need to go to a seniors clinic. The fact that we were unable to have a geriatrician in the HIV clinic, I think, was one of the major barriers. Providers often forgot when they didn't see the geriatrician sitting in the provider room, or when that geriatrician wasn't able to give them direct feedback in the clinic. Patients also didn't want to go reschedule or go into a new clinic. The lack of additional support in our program, we had our social workers through our clinic, but they weren't necessarily coordinating care with the geriatric recommendations and helping to walk patients through the process, obtaining additional consultation for nutrition, helping with advanced directives and home care, and having that coordination of care, I think, was a major barrier to some of the success. In collaboration with a stellar medical student, we actually reached out and talked to many of the existing programs and found that a lot of our experiences were quite similar to others that had a lot of barriers without having that geriatrician embedded within the HIV clinic. So keeping in mind some of these aspects that didn't work, let's now hear from some of our colleagues that have established successful programs. In the panel discussion, we'd love to hear from others who have incorporated or attempted to incorporate geriatric and HIV care. What has worked? What hasn't? Is it improving care? And what are some of the next best steps forward?